Hi and welcome to Physiotutors podcast episode 64 with Dr. Leanne Bisset. Leanne is a musculoskeletal physiotherapist and an associate professor at Griffith University at the Gold Coast, Australia. She has published over 100 papers on a variety of topics and has done extensive research on lateral epicondylalgia, which is our topic of today's episode. Hi, Leanne. Welcome to the podcast. Great to have you.
Thanks, Kai, and thank you for having me. It's a fabulous opportunity to share the work we've done over the last 10 to 20 years.
Sure, definitely. Hey, I've prepared a lot of questions, so we'll just jump right in. And let's start with maybe a quick definition. So, lateral epicondylalgia. Could you please give us a brief definition and maybe which muscles are affected to have a bit of a background?
Sure. To start with, I'd like to say the current terminology, as you know, the terminology and what we call this condition has changed over the decades. The current terminology that people are using is tendinopathy. So it's lateral elbow tendinopathy is now the current preferred title for this condition. And it is recognised as a classic degenerative type tendinopathy, similar to what's seen in Achilles and patella tendons in terms of the morphology. So it affects mostly the common extensor tendon, which originates at that lateral humeral epicondyle of the elbow, the outside part of the elbow. And the common extensor tendon is made up of extensor carpi radialis brevis, extensor digitorum, extensor carpi ulnaris, and extensor digiti minimi. And so what we see in terms of the makeup of these muscles and the coordination of these muscles, their role is essentially to extend the wrist actively and to extend the fingers. However, the function of these muscles is to stabilize the wrist. So if you think about the way our hand works, these muscles have very little force applied at the elbow itself in terms of flexion extension forces or anything like that. But their primary role is at the wrist, and their primary role is to stabilize the wrist so our hand can work. And they're there to, especially the wrist extensors, to counterbalance the long finger flexors that allow our fingers to flex and grip and pick up objects and manipulate objects. So the wrist extensors really work isometrically most of the time, unless it's low load activities such as writing or throwing a dart or doing fine craft work like needling or knitting, where wrist movement takes place and where we need more proprioceptive control of the wrist. But heavier loads, the function is isometric contractions, right? So that's a really important point because our tendency, and I'm going to jump straight to treatment here, but our tendency when we go to deliver treatment and exercise for this condition is to do concentric, eccentric wrist flexion extension under load. And so I would challenge listeners to think about that and think about the role of these muscles and how they have to work for the individual person, and to prescribe accordingly, prescribe appropriately depending on what their activity is. So in terms of the actual muscle contribution to the tendinopathy, it seems to be ECRB, extensor carpi radialis brevis, that is most responsible for the symptoms that these patients present with. And it tends to be the deepest part of the tendon, so it lays closest to the radiohumeral joint and the capitellum and the head of the radius. And Jill Cook actually showed under ultrasound guidance a really nice cam effect of the head of the radius from supination to pronation. And as we pronate, the head of the radius tends to come up and push on that undersurface of the common extensor tendon. And that's possibly that compressive load. Jill talked about it being protective, but it may also be part of what, I guess, in an overload situation, induces pathological change in the tendon as well.
Okay, thank you so much for that introduction. And I think I will have to change the title of this episode and the introduction now, because I'm kind of outdated. And I'm actually surprised that Jill Cook is doing research on upper limb tendons, because I know she's like all about the lower limb tendons, and she also mentioned that in her course. And to follow up with another question, because we moved from, like you said, we moved to a new term, and in the past we used to call it tennis elbow. That's probably the lay term for it, but also epicondylitis, hinting at some sort of inflammation. Why is that inaccurate, and what is the current research saying about the story of inflammation, yes or no?
Yeah, it's a really good question. You're right. There's been a bit of a pendulum swing over the years regarding this issue of inflammation. So originally it was assumed to be an inflammatory condition. And then Harkin Elfington did some really nice microdialysis studies and then found or reported that it's primarily degenerative. And certainly macroscopically, when you look at the tendon under surgical conditions, it's degenerative. It's full of mucoid fatty infiltrate. There's disorganized collagen matrix. And it's hypercellular. There's an increased number of tenocytes within this degenerative tendon. That's usually a portion of the tendon with surrounding normal healthy tendon around that degenerative portion. Since that work has been done, and we went through this phase of saying, okay, it's not inflammatory. Again, more work and more understanding around, I guess, neuroimmune responses and the role of the nervous system in development and maintenance of pain as an experience has found that there are some signs of inflammatory mediators, particularly cytokines, in surrounding tissues. And the thought is that it's not necessarily from the tendon itself. It's from the nerve endings that are in that area and our peripheral nervous system releasing neurotransmitters that are pro-inflammatory mediators. So they then end up inducing mast cell breakdown and this release of cytokines into the periphery. So you may see patients present, particularly more severe cases, and not necessarily really super chronic. They can be, but high pain levels. And you might get these patients who present and they look red and they look puffy in that area of the elbow. And so it's feasible that, given what we understand now around neurophysiology, that there is an element of neurogenic inflammation in the area. It's not to say everybody has that, but it's something to be aware of.
Okay, and for if I take myself as an example, I'm a tennis player and I had tennis elbow twice, I think, in my life. If I get pain in that area again, would you say that's probably the reactive on degenerative case? Assuming I have a high chance of showing some degeneration on ultrasound or other imaging techniques?
Yeah, look, if you ultrasound your elbow, Kai, you'd probably have degeneration there. You'd have age-related changes or just, changes associated with the loading that your tendon has gone through over time, and not necessarily be symptomatic. And I think that's really another really important message for our patients to hear. And yes, I think tennis players, so athletes, are slightly different oftentimes in their presentation, and it's important to get the history of loading if you do see athletes. If you see people who come in having played tennis, what's changed in terms of the development of their symptoms. Sometimes they're insidious. They just come on. There's been no change to load on, their training program or their playing schedule, but the pain just comes on insidiously. And in other times it's linked to a particular overload or an accumulation overload event. And so it is possible that there is more of that reactive on degenerative process going on in those real overload situations. Same goes for heavy manual workers. So they often take time to come in and seek treatment. They don't always seek treatment straight away.
Yeah.
They tend to try and manage it, as do probably athletes. And so by the time you see them, they may be, have had it for several weeks, but there may have been, careful questioning is important, because there may have been a precipitating event, something that triggered this. And in those people, they might show signs of a tear, or larger, a large area of damage than you may see in just your classic degenerative process. But regardless, it's usually in people aged over 40. So if someone's presenting and they're only 20, 25, be really careful with your differential diagnosis. Tennis elbow, and it's still called that colloquially, or, as just a layman's term. So we still definitely call it tennis elbow, and patients relate to that. It doesn't happen in young people.
Yeah, I feel old now.
Sorry about that.
Already having had it twice. We already started answering my two next questions, which are, what are the risk factors to develop this condition?
Yeah, high load typically is the main one. So what is high load? Some of the work that's been done has found working with 4.5 kilograms, so very specific numbers, for greater than 1 hour in terms of lifting and handling that kind of a load.
Yeah.
So that's the level of overload that they usually are talking about. The other thing that's a risk factor is awkward wrist postures. So working with the hand and the arm in really awkward positions. Here on the Gold Coast, I see marine mechanics who work on engines in boats, and they usually have to crawl into really tight spaces and get into really awkward positions to access the machinery and the equipment, and that's a high risk. There are also opportunities for things to address and modify. So when you're managing these things, be aware of, one, the load factor, and that posture, that upper limb posture as well. But I would also say overload is relative. So for and I know this is going to sound depressing, but for a postmenopausal woman who does nothing more than maybe some light gardening work, and otherwise is a fairly sedentary, in their lifestyle, then overload doesn't have to be much. It may be a couple of hours on the computer using a mouse, for example, or an extra heavy day in the garden. So it can be relative.
Makes sense. Yeah.
Yeah.
And as a follow-up question, because that was the second question we already kind of answered, is what is the typical patient? You already mentioned above 40. Is it more male or female? And we already covered occupation. So heavy manual labor is one typical characteristic. What else?
Yeah. And this probably also goes back to the risk factors as well. So equal men and women in terms of distribution, mostly dominant side, so related to, again, that activity in the arm, over 40. And the other factors that predispose that you may see more likely, obviously workers who do upper limb, repetitive upper limb work, factory workers, the manual workers, anything, let me think what else we're talking about. Mostly those are the critical ones. In terms of other factors, if you're talking athletes, then change in equipment, change in routine, training routine, playing routine can be a factor. It is prevalent in tennis players. The prevalence is around about 40%. The majority are not the professional tennis players. It's more the recreational tennis players. It's prevalent in golf as well. It's 5 times more prevalent in golf than golfer's elbow. So perhaps it should have been called golfer's elbow, not tennis elbow. But
that's funny,
as we know, golfer's elbow is medial epicondyle. So it is common in athletes for sure. It's also more prevalent in people with systemic comorbidities. So diabetes is a classic one, that's been linked to tendinopathy. But other things as well, like almost those pre-diabetic signs. So hypercholesteremia, so hypercholesterol in blood, gout. So some of those other systemic pro-inflammatory type conditions, they have an increased risk of developing tendinopathy. Interestingly, there's also some links to some medications, statins and some of the antibiotic groups, the fluoroquinolones, I believe, are linked to tendinopathy as well. Now, most of that evidence lies with the lower limb, where they've found, rupture of Achilles tendon and things like that. However, it may well be something to consider if your patient has been, reports being unwell recently or anything like that.
Yeah, very interesting stuff. And I have to admit, I already had golfer's elbow as well, caused by tennis. So, I know what you're talking about. So, and by the way, if you have any studies and authors' names, you can just throw them out, because afterwards I will find them somehow on PubMed or with your help and put them in the transcript as well for people who really want to dig deeper.
Go back and look.
Yeah.
Sure.
Are there any red flags when we start our diagnostic process that we need to be aware of? You already touched on a tear. Could you maybe talk a little bit more to us about that?
Yeah, so I guess if you're talking red flags as in cancers and those really serious health conditions, they're no more prevalent with this condition, I guess, than general musculoskeletal injuries. So as your normal screening questions, they would be sufficient to apply here. There are other things to think about, though, in terms of establishing the level of severity for the condition and prognosis, I guess. The involvement of the lateral collateral ligament has been implicated in people typically with the more severe presentations of tendinopathy, and also with people who've had a history of corticosteroid injections as well. Now, that's not yet been confirmed as a causal relationship between the corticosteroid injection and the involvement or the breakdown of that lateral collateral ligament. But there's sort of some work and some speculation around those two things being linked. But certainly in the more severe cases, the lateral collateral ligament is involved, and that is the primary restraint to various forces. So every time we lift up an object, particularly with our arm outstretched, there's usually some type of varus force being applied at the elbow. And so that I think is something to consider, especially in those severe presentations, that you incorporate stress testing of that lateral collateral ligament and that head of the radius in your presentation, because they may well be part of that pain presentation, and it's quite different to the tendinopathy on its own. So pure lateral elbow tendinopathy, the pain is pinpoint over that epicondyle. It's aggravated by palpation straight over the epicondyle and just that first centimetre or so where the tendon lies. It doesn't radiate, not the tendon, not if it's pure tendinopathy. It's aggravated obviously by gripping, particularly in an extended pronated position, wrist extension, like this resisted wrist extension, and resisted middle finger extension. And that's primarily loading ECRB.
Yep.
Okay, and through that base, inserts onto the base of the third. So diagnostically, it's a fairly simple presentation to diagnose. If the patient's complaining of pain elsewhere, round the back, down the side, down over the extensor forearm, up the forearm, then you need to start thinking about your differential diagnosis. Palpation's really a very cool tool, if you know your surface palpation, to use to try and help differentiate potential structures that are contributing to that pain presentation. So we can palpate the epicondyle and that common extensor tendon. You can palpate the radiohumeral joint line, the lateral collateral ligament. It's quite a taut band that we can feel through that joint line. The radial head of the radius as well, and of course the radial nerve is the other thing. So palpation's a really neat tool to use with these patients to try and help tease out, do you think other structures are involved? If you think the head of the radius, so the head of the radius is likely to become subtly unstable. And there is work, and I will send you through some reference list later on, Guy, about these. But there's been some work to show that around 40% of patients with chronic recalcitrant lateral elbow tendinopathy who presented for surgery, 40% of them had involvement or instability in that radiohumeral joint through a loss of integrity of that lateral collateral ligament. And that was previously undiagnosed prior to surgery. So it's something to think about. And those patients where that radial head might be subtly unstable, you might find they get pain on loading, for example, of the biceps. And it may still give them that lateral joint pain, but it's biceps contraction that aggravates. Elbow flexion aggravates rather than extension pronation. So if you're getting some, if the patient's complaining of different types of aggravating factors besides extension, pronation, gripping, then think about those other differential diagnoses.
40% is a massive number. So that's
that's the ones though that went to surgery. So it's only around 10% of the whole population that actually end up going to surgery. And there's been quite a few studies that have looked at that in terms of that progression. Yeah, so it's not 40% of everybody with elbow tendinopathy, but just those that go to surgery. Yeah.
Okay, clear.
But still significant.
Yeah, definitely. And does it make a difference if someone has a tear, or do you not consider this a red flag, or management is still the same?
Yeah, good question. Okay, so I'm going to put a bit of a clinical hat on here and a bit of a research hat. So there is some research, but it was published back in about 2010. So it's a good 13, 14 years old now. And ultrasonography has come a long way since then, right, in terms of developing the images. But back then there was a study that found the involvement of a tear, or the inclusion of a tear, as well as the degenerative change in the tendon, was prognostic of a poorer outcome at 12 months follow-up. Yeah. So there has been some work done on that. However, I've talked to musculoskeletal ultrasonographers about this quite a few times because they are the ones, doing these scans on a daily basis. And in actual fact, they have confessed that it's very difficult to identify a true tear as opposed to the degenerative blob for want of a better word, the degenerative portion of the tendon. So because the tears are often, what do you call it, like in parallel with the line of the fibers and the collagen matrix. So they often run lengthways along the tendon. So they sit flush. So if there is a tear, it often will sit flush against the fibers and they can't necessarily see that it's a tear, as opposed to a degenerative area within the tendon. They typically will look for lines if they can visualize them. The sonographers have said that really the way to diagnose it is to inject some fluid into the tendon, so some saline, for example, and watch the fissures separate. And if they see that separation of fibers, then they can be more sure that it's a tendon tear rather than just that degenerative portion. So I think I'm a little bit skeptical about the evidence of tears necessarily being a poor prognosis or not. I think if there is a tear, it's important to marry it up with the history. If their history is insidious and it doesn't fit a picture of an acute injury of some sort, of an acute overload or an acute trauma, I put less importance on this, this report of a tear, as opposed to someone who does have a history of, deep sea fishing and fighting a massive, 200 kilo fish for an hour. The chances are that really is a tear under those sorts of loads, Yeah. So I think it's important to just marry it with your patient.
Okay. We just talked about, or we already talked a lot about diagnosis and red flags. So a specific red flag, just to summarize everything we just covered, would be check the LCL to see if it's involved or not. That would be, in my perspective, a specific red flag in the elbow or something to definitely check on. Diagnosis is, really a specific location, pain, so not radiating pain. If you want to diagnose lateral elbow tendinopathy, you already mentioned the different tests, like the Cosen's test, basically the Moseley's test.
Yep.
I don't know if you use the Mills test, like the stretching. I often don't find it positive, like it's not so not aggravating as the other ones, in my experience. And we talked a little bit about ultrasound, and I have a follow-up question, and then we can maybe add something to the diagnosis. Is do you use ultrasound, and do you consider it valuable? Because we just talked about the limitations of it. Do you use it in practice?
No, short answer. The limitations are also that Luke Hills did this body of work, that around 50% of the healthy, pain-free population with no history of injury have changes on ultrasound imaging of their lateral elbow tendon. So it has a high sensitivity. So in the absence of any changes seen on ultrasound, you can rule out tendinopathy, but a poor specificity. So it's not a diagnostic criterion for lateral elbow tendinopathy. It's useful if you want to differentiate tendinopathy out. The problem is that so many people have changes on tendinopathy. More often, the imaging is detrimental to the clinical picture, because they get sent for an ultrasound scan, and chances are you've got 50-50 chance for people over the age of 40 that they're going to have degenerative signs in that tendon, and that may not be the source of symptoms. So don't rely on imaging for your diagnosis of tendinopathy, would be my message here.
Okay. And was there anything that you would like to add to your diagnostic approach?
Yes, I think in addition to lateral collateral ligament, that instability in that lateral part of the elbow, I think one of a good way to frame your diagnostic approach for these elbow conditions, particularly because they often present chronically, right? That they don't come for treatment or seek treatment until they're maybe sometimes several months down the track. They might have gone through the GP, first and had scans and maybe an injection or something like that, or they've just managed it on their own. Thinking about pain mechanisms, I think, is a really helpful diagnostic tool in these patients. The thing that makes the elbow different to the Achilles tendon, to the patellar tendon, is that the elbow has 3 very large nerves running through, around, within these muscles under these tendons. And so part of your differential diagnosis has to be consideration of, 1, neuropathic type pains or nociplastic pains. And some of the work recently published in 2022 that Paul Hodges led was a major consensus study looking at the diagnostic criteria for different pain mechanisms. And I think that's really helpful in terms of trying to work out whether you think it's just the tendon or just the joint or the ligament or some local, structure, versus are we talking about nerve involvement as well, or are we now talking about central nervous system involvement? And so I think those are really, really good learning tools to keep in mind. And bear in mind that there can be a spectrum and that people can present with multiple pain mechanisms, not just one, they're not discrete.
Yeah, cases are never like in a book or like you learn it during your studies. Never black and white, unfortunately.
No, far more complex, aren't they?
Yeah, definitely. Let's move on to treatment. I mean, you already mentioned that, quite a lot of therapists, myself involved, focus too much maybe on concentric, eccentric, although the action is more an isometric action. So how would your management or exercise approach look like?
Yeah. So there's been, a couple of systematic reviews done recently in the past few years that have found that exercise does offer benefits over passive modalities, but the conclusion is that there's small effects in terms of the difference. And that sounds kind of depressing, I think. Yes. You think, exercise is the mainstay, the main go-to. And it makes sense. If it's a tendinopathy, we know there is this capacity for tissue healing and repair, regeneration, with optimal loading. So overload and you'll, cause more pain and tissue breakdown. Underload is equally not beneficial. So we do have to find this sweet spot, if you like, for tendon loading, and it makes sense. Functionally, as we've talked about, it makes sense, at least in the beginning, to start with isometric loads. There's not a huge body of evidence out there for isometric exercise on its own. And what is out there has found that as opposed to healthy populations where isometric load has been shown to have a hypoalgesic effect, so it relieves pain. That's not the case in musculoskeletal pain conditions, including elbow tendinopathy. The work that's been done has shown it doesn't have a hypoalgesic effect. In fact, if you exercise into pain, all you do is increase their pain. So it doesn't have a flow-over effect in terms of improved function or anything like that. And there's been a few studies there. Brooke Coombs did one looking at isometric exercises above pain versus below pain threshold. And into pain just caused more pain. That was all it did compared to below pain threshold. And it lasted a while after. I would also argue that if there's no physiological benefit to exercising into pain, there's nothing today that's been demonstrated anyway in elbow tendinopathy that you risk poor adherence to a home program if you push hard into pain. The upper limb, and I don't know what it is. I can't tell you that I haven't done the research, and I'm not aware of any research that's showing that people perceive arm pain differently to leg pain. But it just seems to be more critical in the arm when patients will come and they've been given exercises, and you say, "Oh, can you show me?" And they say, "No, I haven't been doing them because they hurt."
Yeah.
And you can understand from the patient's perspective when loading it was what caused this problem in the first place, and then we go and tell them to load it more to fix it. It's a fine balance. We need to educate our patients, of course, into what we're doing, but I think we have a responsibility to prescribe exercise appropriately. So firstly, my advice would be start isometrically if that's relevant to your patient.
Mm-hmm.
The second part to that is that there is a growing body of evidence, and there's systematic review by Lateral on this that has shown manual therapy has a role to play in the management of this condition. It improves grip strength. It decreases pain hyperalgesia in terms of pressure pain thresholds and things like that. And clinically, it helps patients increase their loading in a pain-free manner. So if we can change pain-free grip strength by applying a manual therapy glide in the clinic, then teaching the patient themselves to apply this glide at home as a self-mobilization technique has this potential to improve adherence. They're going to do exercises if it hurts less, and two, actually load more quickly and progress more quickly if you can control that pain experience. And I'm going to call it nociception. We're assuming we're making changes to local nociception, but it could equally be changing these pain modulation effects higher up as well into the spinal cord and the central nervous system. There's some evidence that manual therapy has got that global neurophysiological effect.
Okay, I'll try to summarize a little bit, and then I'll ask more questions. So first of all, you'd say don't exercise above the pain threshold. Doesn't seem to be a good idea.
Yep.
And we said, okay, isometric loading makes sense if it's relevant to the patient. How would that look like in concrete? Am I taking a dumbbell and I'm just holding it somewhere midway with a challenging weight that is pain-free for my patient? How long? How many sets?
Yep.
Give us the details, please.
Okay. Yeah. So the way I normally start my patient off with isometric exercises is I tend to use resistant band initially, because you can control the resistance and you can fine-tune the position a lot more easily with that. So I tend to start with just using resistance band, and I usually tie a loop and loop it around the back of the hand so they're actually not having to grip. So they're not facilitating their finger flexors. They're just concentrating on wrist extension. So it's looped around the back of their hand. Watch wrist posture. Some work we did over a decade ago now showed that in these patients there often is a change in their spontaneous wrist posture. And if you watch these patients and observe how they grip when you ask them to perform a pain-free grip test, which, by the way, you should do an extension pronation. So I know the standard position is elbow flexion 90 degrees neutral forearm, but it's most provocative and most sensitive to change if you do it in extension pronation, elbow extension. So either standing arm by the side or even supine lie with the arm by the side. The next step is to find a starting position that's not painful. So elbow bent closer and the arm close to the body, so elbow tucked in their side is a good starting position, and then move into pronation. And if they can do that, then I start to see how far out they can extend their elbow before pain starts, and then come back. Then time it. So the resistance band I would choose depends on the person. If they're very weak, you start with something really, really light and work up. Time how long it takes for them to develop pain. So use time in that initial instance as your outcome measure and position. So then your progress can be increased time, changing position into further and further into elbow extension, and then increase your resistance over that. So for loading isometrically, that's a really nice structured way. So in terms of repetitions and time targets, I would usually try and aim for a longer duration, but only up to, what I have done clinically is up to a maximum of a 1 minute hold, and then rest and then repeat. I teach patients a self-mobilization technique, and typically the easiest one to do is that PA on the radial head, getting them to hold if it changes their pain. So test without, test with, and if it improves their pain-free hold duration, then test it, then get them to do it. I also get them to do that with elbow flexion and extension repetition between exercise reps to clear the pain, because oftentimes they'll do an exercise and they won't feel pain during, but then they'll go to move after and it'll be like really stiff and sore, like almost like a rebound effect. Clear that. Don't let them hurt. Okay, this becomes their pain medication. They can do those mobilizations whenever they feel aggravated with their pains. And I would repeat that then in the beginning stages, like day one, less is more, because my goal is not to start targeting tendon regeneration straight away. I need adherence first. I need trust. I need to know that they feel confident doing these and that they're going to do them correctly. So I would usually start with something really small, like maybe 3 to 4 repetitions in day one. Now, the work that's been done with using mobilizations with movement in the clinic, Bill Vincenzino's work, initially the prescribed treatment in clinic for that gripping as the exercise was to do 6 repetitions. Okay. So it's still only a few. It's not 3 sets of 10. It's like 1 set of 6. I do 3 times 1 minute holds for a home exercise program to begin with. And then there's room and teach the patient how to monitor it, how to time it, how to review their own symptoms and what they're experiencing. And they can adjust it up or down based on how they feel they're responding. And that gives them control over this exercise. It puts them at the center of doing it. And I find that far more effective than saying you must do 3 sets of 10 or whatever. Make it very much individualized to them. Yeah. Now, having said that, from there you can progress it. Viana Buvan's work has looked at the endurance capacity of these muscles in terms of holding a sustained weight in men and women. Obviously, the weight was different. And what she found in healthy controls is that women could hold, now this is with a bent elbow, forearm resting on the table and then the weight off the table. She found women could hold a 2 kilo weight for maximum endurance, which was like 7 minutes or something, so a long endurance. For men, it was 3 kilograms. So that was for healthies. And that gave us a potential target to get to. Now, I don't necessarily prescribe that as a target for all my patients, but for men in heavy manual work, it's maybe a reasonable target. 3 kilos for 7 minutes you should be able to hold without pain, and without pain aggravation. So there's a good kind of strategy that Viana developed, which was to use a fluid-filled container, like a jerry can. Do you call them jerry cans? Like a water
Yeah, I know what
bottle.
you mean for sure. Yeah.
Yeah, of some sort. So you can start with a volume, measure a volume that is pain-free for, say 30, 40 seconds, a minute, hold. And then each week, what her prescription was, and this was a complete home program, not coming in for review by the physios, was an incremental increase of about 100 to 150 mils or something like that per week, gradual increase in load over time. So that's another way using water. The difference there is that you're gripping. So you've got you're loading the extensors through this co-contraction agonist-antagonist relationship between the flexors and extensors, as opposed to with the resistance band, you just start with the band, the extensors.
Okay, and would you have people exercise every other day or on a daily basis?
In the beginning, daily. And when the reps are very low, I try to get them doing it pretty quickly, a couple of times a day. Mm-hmm. As I said, it's not about, in that early stage, it's less about loading for tendon to develop enough tendon strain to get a physiological change. Yeah. It's more the psychosocial benefits of exercising and showing they can do it and that it's not aggravating their pain. So little bits, but a bit more often in those early stages. And then as they start to improve, as pain comes down and you can start to really start targeting load a little bit more, then higher loads, 6 repetitions once a day or every second day, depending on what they're doing. Adding in the global upper limb strengthening, though, is also really important. And I would implement something fairly early in the rehabilitation program because there's evidence to show that there is global upper limb weakness in patients with especially chronic tendinopathy around the shoulder, scapular region especially, and biceps and triceps. And again, Brooke Coombs has shown biceps, triceps weakness in patients, particularly with more severe symptoms. So to start with, easy non-painful exercise is a push-up, but usually it means starting against a wall and then gradually, loading down into the floor. Now, the patients who don't respond well to that are patients who have got any instability in the elbow. So if there is instability in that lateral complex, then push-ups will make them worse. And you'll usually then flick to the tabletop test is
just
something.
About to mention that one.
Yeah, it's a neat one to try and help you differentiate. If they do a push-up and they go, oh, that hurts, then apply a PA, sustained pressure, to the head of the radius, get them to repeat it. And if that relieves their pain, it kind of is an indication that they might have some of that posterolateral instability in the elbow, in which case, weight-bearing exercises are probably not the go-to thing. Can I just add the other thing I would do if I'm prescribing exercises and my target is pain management? I tape. And I know that people are sort of going, hands-on, too much hands-on, you're doing manual therapy and you're taping. But as I said, it's this this relationship with pain, I think, is quite critical in these patients, and getting it right is important. And there's good evidence that tape has an immediate effect on reducing pain, as long as they're not getting skin sensitivity from wearing tape. I would apply tape and send them home with it and say, wear it for days, 4 or 5 days if you can. Oftentimes with tape these days, it doesn't matter if it gets wet, it still sticks. Doesn't matter if it gets ratty, doesn't matter if it gives them pain relief. Is it a placebo effect? Possibly. Yeah. Although the studies that have looked at immediate effects have found that the taping technique is superior to a placebo, at least those immediate effects. Long term, I mean, the thing with placebo effects is they often are short lasting. They don't last long time. Tape seems to have a prolonged analgesic effect. So use it. If it's a gateway into getting people to exercise and comply and adhere to an exercise program, use it.
Okay, and that would be a tape on the ECR or a tape of the radial head into a lateral glide direction?
So a couple of different taping techniques. One is the diamond deload. Yeah. So this was, I need to get the first author for you, but again, it was a study that was Bill Vincenzino was a senior author on, and they used a diamond deloading tape. So it's a diamond-shaped taping technique where that common extensor tendon sits in the middle of the diamond, and that's effective at reducing that hyperalgesic especially to palpation over the lateral epicondyle. I also find that taping technique really good if you have a patient whom you suspect has neural entrapment or neuropathy type symptoms. So whether it's within the posterior interosseous nerve at the level of the supinator, or higher up in the radial tunnel, that deloading technique can be quite effective at easing some of that neuropathic type pain as well. And the same even with nociplastic pain to a certain extent. So as a pain tool, that can be quite good. So it's not necessarily a biomechanical effect on any of the underlying tissues. It just seems to have this analgesic effect in itself. The other one that I will use is a spiral taping technique that simulates one of our manual therapy techniques, which is a lateral glide on the elbow. So from the ulnar side, gliding laterally while you're stabilizing the humerus. So the spiral technique for that is starting on the medial side, distal to the elbow crease, so on the ulnar, spiraling anteriorly across the elbow joint to finish laterally up on the humerus. And if you apply that technique with the elbow in maybe about 30, 40 degrees of elbow flexion, careful you don't crease the skin on the tape at the front of the elbow, then that will tighten up in extension pronation. And that again seems to feel, patients will say it feels stable, feels supportive, and again has an analgesic effect. So test it in the clinic for that analgesic response. Give your patient appropriate advice about how long to wear it, what symptoms to look for if it's starting to become annoying or irritate the skin and things like that. But use that as an adjunct to again help improve and progress your exercises a bit faster than you would otherwise be able to.
Okay, talking about progression. Now let's say we have an athlete who does the isometric loading, probably with a higher load. How do I progress this patient? And let's also assume that he or she is doing the lateral glides to help with exercise even more vigorously or with pain relief. How do we progress this person in terms of exercises? Let's say we have a professional tennis player, for example.
A tennis player? Yeah, so the progression needs to be focused on getting them obviously back to sport, back to training. Usually with athletes, I will check in if they've got a coach or if they've had any, often with recreational athletes especially, they've not had any formal training. So sometimes stroke correction is a really important part of their rehabilitation. If they're seriously keen to get back, even golf or tennis to get back, to look at stroke correction and making sure things like the racket size, the grip and all of those sorts of things, the tension on the strings, all of those external factors that do influence load on the elbow are addressed and are optimized, if you like. In terms of progressing the exercises, the progression needs to be obviously increasing load, but it then needs to be it's not static. So you can still load the extensors isometrically. So particularly with tennis, right? There's not meant to be flex at the elbow when they impact the ball. So the exercises, sometimes we think about them being plyometric, like stretch release type of things. But in the case of this, it's not a stretch release. These are not, and this is one of the differences between the common extensor tendon and, for example, the Achilles tendon. This is a positional tendon. The Achilles tendon is an energy storing tendon. So the Achilles is meant to stretch, under load and then release. And it has a higher percentage of elastin in that interfascicular matrix. Positional tendons, now this work was done by Hazel Screen out of the UK, and she's done it on horses. So again, I'm extrapolating here. The work hasn't been done on humans yet to say for sure, but the equivalent of the positional tendon in the horse foot or leg is the common extensor tendon of the elbow. And it makes sense. It's a positional tendon that's designed to position this arm in space, not to store and release energy. So the wrist is still isometric, but the movement comes at the elbow and the shoulder with the progression of exercise. So you can still do free weights or cable or band weights. You can add a racket or a golf club to lengthen that and to load through that increased momentum. And progress it that way. So you're loading and you're using the whole upper limb more in a functionally specific manner rather than just doing static isometric holds. That's usually the progression I would go to. In some cases, and mostly probably with the manual workers who are doing high-level work, so hammering or hammering, who are working in awkward positions with their wrist, I will still go back to a concentric eccentric program as well. So there are situations, I don't say never do those. If it's relevant to the patient, then concentric eccentric load is certainly something to consider in those individuals as well. And again, for the men, I would be aiming for a 3 kilo. But you try lifting a 3 kilo weight through wrist flexion and extension, especially in an extended supported position, it's full on. It's heavy. Yeah.
I do have quite some questions left for you, but I'm just checking the time, and I think we already crossed the 1 hour mark. So I'll ask 2 more questions, and let's try to answer them briefly. How much pain do you allow, or what is the pain reaction? Because in like the lower limbs, we often use the 24-hour pain rule, so a little bit of aggravation is okay. If it settles, would that be the same in the elbow?
Yes, it's pretty much a similar sort of rule of thumb in the elbow. Again, it depends on the patient. If you suspect a lot of hypervigilance, poor self-efficacy with these patients, I would back it off until we get their confidence. But generally speaking, as they get confident with it, I would say no more than 3 or 4 out of 10, and it should settle by the next day.
Yeah.
Ideally, I want it settled within sort of half an hour to an hour after doing exercise rather than it lasting all day.
Okay. Yeah.
If you suspect neuropathic pain, then I don't think that rule applies. I think you've got to be far more conservative with pain aggravation if it's neuropathy.
Yeah, I agree. Okay, and what would be the course that we can expect from tennis elbow? How long does it last?
So there's been some really good RCTs with long-term follow-ups where we've delivered 8 treatments over 6 to 8 weeks and had improvements in the short term, so at that 6-week, 8-week mark, that have been sustained for the long term. So there is really good high-level clinical trial evidence that around a 6 to 8 week program is sufficient for tendinopathy to recover. Okay. Mm-hmm. We did another clinical trial where we only gave them 4 treatments, so once a week for 4 weeks. So we halved it, and we haven't published this, but we do have the data and have looked at the difference. So the physio program was identical. The effect size was half. So there is evidence, and we will publish this one day, there is evidence that in the case of tendinopathy, 6 to 8 weeks is better than 4 weeks in terms of getting higher success rates.
Okay, interesting. And a last one, and then we really try to finish off.
Okay.
What about shockwave and or dry needling? Because I've seen it's recommended in some guidelines even.
Sure. Yes. So the latest Cochrane review, and it's probably a few years old now, there's a lot of studies out on shockwave therapy, and the people who are in favour of it will tell you, well, there's different types of shockwave and all of that sort of thing. The last Cochrane review reported platinum level evidence. Now I don't know how much higher that goes from gold, but it's platinum level evidence that it is not beneficial in tendinopathy, in elbow tendinopathy. And when we've, it's a little bit older now, but we published a general clinical opinion paper back in 2015, and we did a bit of an update at that stage on shockwave therapy, and we found people who had shockwave were worse off than the control population or placebo. So for lateral elbow tendinopathy, I'm not a fan of shockwave therapy. Dry needling, there is evidence that acupuncture can help with pain management, and dry needling. So the evidence is a little bit less clear, but probably using similar guidelines. That if it's there to manage, I think for the pain management, rather than necessarily stimulation of tendon repair. The reasoning behind it might be, a little bit different. But, I think for certain patients, dry needling may well be a good adjunct.
Yeah, I wouldn't expect any repair on the tendon through the dry needling anyways. I think we're not even sure if we can achieve this with exercise, right?
Yeah. True.
Okay. I think I would still have a lot of questions to ask you, so we might have to bring you back at one point.
Yes.
Is there anything that we haven't covered that you would like to add, that you feel like, I didn't mention this, but this is really important?
Just trying to think, look at you. Modalities. So braces, people often ask about orthoses and
that's
wearing braces. Do you wear prescribe, not prescribe? So Luke Hills again did a systematic review looking at the body of work around orthoses for lateral elbow tendinopathy, and it seems to suggest that they can be helpful for immediate changes in pain. The choice of brace is probably less important. So there's not really any high-level evidence to say one brace is superior to another. The thing with braces, clinically, I find if they give some benefit, by all means wear it. It's certainly easier to apply than taping, if it's helpful. Be careful and make sure you educate your patient around how to apply it and how tight to apply it. Patients will often go and buy one from the pharmacy and wear it. And as the day goes on, if it's not helping or they develop pain, they'll start to tighten it up and they'll think, oh, it's not tight enough, I have to tighten it. And I've seen some cases where they've almost given themselves a neuropathy because they've got this constriction going around their forearm. So, again, the radial nerve runs right under that common extensor tendon and in that area. And if they start really compressing hard, I think it can be detrimental to them. So if it's helpful, wear it. If it's not, don't wear it, is usually my advice to patients.
Okay.
I think that's it.
Yeah, our last question is always, where can people find you if they have more questions that they would like to ask?
So I am on Twitter at Leanne Bisset, all one word. I'm on LinkedIn. I tend to don't look at it every day, put it that way. The other thing is search Griffith University, and by all means drop me an email to my university email address. I'm more likely to see that sooner rather than later. I guess I'm going to IFOMT this year in July in Basel. So I'll although you probably don't want to put that if it's going to move on, but 2024 I'll be in IFOMT as well.
Okay. Leanne, thank you so much for your time and knowledge. It was a pleasure to have you.
You're very welcome. Thanks for having me. It's been great and well done. I like the fact that you guys are doing this and releasing it, globally. I think it's really helpful. Let's get messages out there.
Sure. Okay, so thanks a lot for listening to this episode, to everyone listening out there. And as always, to access the transcript and additional resources, make sure to download our new and free Physiotutors app and benefit from more useful physio content. And if you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts. And also consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll talk to you in another episode. Bye.